Hello, and thank you for joining this brief webinar on screening for early psychosis in primary care settings. I'm Monica Calkins, and I'm a professor of psychology at the University of Pennsylvania and the co-director of the Pennsylvania Early Intervention Center, also known as Heads Up. So when we think about screening, some of the challenges that we consider is just the backdrop of schizophrenia and other psychotic related disorders. So schizophrenia and other psychosis disorders are neurodevelopmental disorders. This schematic from Tom Insel, who was the director of NIMH, it shows very nicely an illustration of how individuals who are developing schizophrenia and other psychotic disorders already have brain changes occurring long before the clinical symptoms in the prodrome stage or in the first episode psychosis stage occur. Now, ideally, we would identify and treat young people before symptom onset, but unfortunately, currently there is no way to fully predict outcomes and no medications available to treat attenuated symptoms that may occur prior to the onset of psychosis symptoms. So we are challenged to try to identify young people before their symptom onset and instead focus on the very earliest stages of psychosis symptom development. We also know that we need to, at the same time that we are working to develop better ways to identify young people who may be at risk for psychosis, we know that we have to continue to improve access and successive early interventions for the first episode psychosis stage. And so that's why we talk about screening and early identification, is to try to improve that access to the care that does exist for young people who are experiencing early psychosis. Now, this neurodevelopmental path of early psychosis is occurring in the brain, as we discussed, but also there are social adversities that are occurring in the backdrop of the context of other risk factors, including developmental risk factors, genetic risk factors, and so on, all of which then are contributing to a trajectory of an evolution of symptoms over time. And so we know that individuals may experience cognitive, motor, and social impairments, anxiety and depressive symptoms, social withdrawal, and subjective cognitive changes long before the onset of subthreshold or threshold psychosis symptoms. And so our interventions really must facilitate an improved trajectory of individuals' symptoms and functioning. So in the early psychosis screening window, we're really looking to identify young people as early as we possibly can based on the clinical symptoms that we've identified as being potentially predictive. Now, sometimes when people hear about psychosis spectrum screening or screening for schizophrenia or other psychosis spectrum disorders, especially in young people, there are several challenges that we face. One is that people, primary care providers and others may naturally wonder, if someone's talking about hearing voices or having unusual thoughts for them, is this just, you may ask, is this just a normal experience? Or is this just an adaptive response to the person's current circumstances? And that's because traditionally we've had little normative or base rate data to be able to compare those experiences from the individual in front of you to other typically developing children. And so we have addressed that in our work by providing some age norms for our psychosis spectrum screening tool that I'll tell you about. You may also wonder whether, if the person has depression or anxiety or trauma or substance use. You may wonder if the person's talking about unusual experiences. Is this just due to or a manifestation of the depression or the anxiety or the trauma? And what I'll cut to the chase and say is that in the earliest stages, we actually don't try to disentangle, because we know that the occurrence of psychosis spectrum symptoms, especially in the context of comorbidities, even though they don't necessarily mean that a person will go on to develop a psychotic disorder, they do predict reoccurrence and worsening of those psychosis spectrum symptoms or of the other comorbid psychopathologies. And so we encourage people not to try to say what's due to what. We also know that young people can be unable or unwilling to disclose symptoms that they're experiencing. And that parents, collateral informants, have limited knowledge about the subthreshold positive symptoms that their young person or their child is experiencing. Part of these two factors are contributed to by the stigma and fear that is uniquely associated with schizophrenia, which is one of the most highly stigmatized disorders. People worry about a lot of things that they see in the movies and TV and the news that simply are not true about having schizophrenia and what it means to have schizophrenia. We know that people with schizophrenia can recover and can go on to live high quality and happy lives. So we have done some work that shows that more than 65% of young people experiencing persistent psychosis spectrum symptoms do report previously talking to a medical professional or some other professional about their thoughts, feelings, or behaviors. Now, they may not necessarily have been talking about these symptoms, in part because screening for early psychosis symptoms is very rare. Most people nowadays, are starting to screen for depression or anxiety, suicidality, maybe substance use, but it's relatively rare to be asked about these symptoms. But young people are coming into contact with medical professionals. And so we encourage screening, asking about these questions, asking about these symptoms as well. Because medical professionals do have access to a critical window of opportunity to screen for psychosis spectrum symptoms and to connect a young person with appropriate clinical care as warranted. So around Pennsylvania and actually around the country and the world now, many referring organizations are starting to do a pre-screen using structured screening tools to screen for psychosis spectrum symptoms, just as one might for depression or anxiety or suicidality. And at our local Pennsylvania Coordinated Specialty Care Clinics, we have an intake screen in place according to agency needs and preferences, which means that if an individual has screened positive on a screening tool, they're going to go over to our Pennsylvania programs and do a much more thorough specialty evaluation to determine the best course of action for that individual. So that individual may not require the level of care that's provided by our programs, and then we would potentially refer elsewhere, depending on the person's unique circumstances and their preferences. Heads Up, headsup-pa.org, and here's our phone number, can help to guide triage and referral to appropriate programs within Pennsylvania or to alternate referrals as indicated based on the individual's unique circumstances. So to the point that it's important to, when in doubt, check it out. We, can help to connect people early to care or to other resources as appropriate. So we've developed a tool, it's a flow chart for early psychosis screening for pediatricians and primary care clinicians. And what we've done here is kind of laid out a number of different possibilities for what you're going to be looking for if you're considering screening for psychosis symptoms. And first of all, we want to think about whether the person has a positive behavioral health screen. Maybe that's for depression or anxiety or something else, or the person is showing new or worsening functional decline or cognitive difficulties. Cognitive difficulties being trouble with thinking, attention, memory, functional decline being social withdrawal or other social decline, maybe school performance has declined or work performance. Also, we know that having a family history of a first-degree relative, either a parent, a child, or a sibling for a child for older individuals, is a risk factor. And so we recommend screening for subthreshold psychosis symptoms in any one of those circumstances. And then you'll see that there's a number of other indicators that we recommend asking about, especially focusing on whether it's impacting the individual, whether it's conforming to the person's cultural, medical, or developmental context, whether it's impacting their emotions, whether it's reoccurring or progressing. And those are places where you can decide as the person's provider to either monitor and educate, to reassure and redirect, to refer the person for a specialty mental health assessment. You'll notice there's some safety concern cut points, and that's where, of course, if there is a safety concern, that's where a same-day assessment may be warranted. So our screening tool is 5 items. So we made it very brief and in order to really facilitate hands-on use of this tool in primary care settings. And it's a simple questionnaire. You can either give it to the person as a self-report measure or ask the questions. So you read aloud the directions and then you read each statement. So I think that I felt that there are odd or unusual things going on that I can't explain. And the person will rate from definitely agree to definitely disagree with the following statements. Once you've completed the 5 items, then there are 2 ways to score the prime 5. So either way suggests if a person is screening positive on the scale, then a fuller evaluation for subthreshold or threshold psychosis symptoms should be considered. So the first way is to sum the 5 items. You're going to total the items, and then you're going to look at the individual's age and their prime 5 score. A person scoring at or above the prime 5 score has endorsed a level of symptoms that is 2 standard deviations higher than the mean of others their age. So if you're looking at a 12-year-old who has a total score of 18, that is 2 standard deviations away from the mean of their peers, of their age, their age. Conversely, at the higher ages, age of 20, the fewer number of items are needed to reach that level. Another way to kind of very quickly, without having to total it up, is to just think about whether or not a person has endorsed at least one of those items at a 6, definitely agree, or 3 items rated 5, somewhat agree. Those are also red flags for further evaluation and further consideration and potential evaluation. So we do have some follow-up questions that you can ask to kind of get at a little bit more what the person's experiences may be. And these are optional follow-up questions that can help you to distinguish subthreshold from threshold positive symptoms, or even very low-level subthreshold symptoms that you may feel comfortable monitoring, but not necessarily referring out for at that time. So the first thing is really getting what we call the description. So you really want to find out what the person's experience is like. So if a person has said, has endorsed a positive symptom, I think that I might feel like my mind is playing tricks on me. Then we ask, what? Usually we're saying, we're using the 5 W's, the what, who, when, where, and why. What? Tell me about that. In what way? What do you mean? What is that like for you? If a person indicates that they think that an individual might be interfering with their thoughts, who, do you know who that is? When did it start? How often does it happen? How much of the day? How long does it last? How preoccupied is the individual with this? Where does it happen? Does it happen anywhere else? Why? Why do you think this happens to you? And what we're calling this here is establishing the parameters and the context. So you get a sense of whether this is just a one-off, just happened today and it's not really that meaningful. It's not really happening very often, versus something that's much more significant in terms of meaningful for the individual. We also think about, along those lines, how convincing the experience is for the individual, or how much meaning they take from it. So we know that delusions and hallucinations, so a delusion being a false belief, a hallucination being a false sensory perception, do have a compelling sense of reality for the individual. So if I hear a voice talking, I hear the voice talking as loudly as you hear me talking. Someone who has a false belief at some point will believe it 100% convinced. The person will be 100% convinced that it's real. And so there's follow-up questions for asking about that. How do you explain it? Do you ever think it could just be your imagination? Can you hear or see it as clearly as you can see or hear me? And also whether the person is acting on it. If a person's having experiences, but they're not really acting on it, that may be less significant than if the person is acting on it and it bothers them. The person's level of distress, it can be important. So does this bother you? How much does it bother you on a scale of 0 to 10, where 0 is no bother and 10 is extremely serious bother? We also can kind of get a sense of some reality checks, what we think of as, kind of getting some external corroboration about the experience. Have you talked to anyone about this? What did they say? If someone says, well, they said that there's nothing there and they don't know what it is, that's different than saying, oh, yes, they heard that too. So there's some really basic reality checks. Also, of course, if you have a parent or another loved one available, asking some additional questions about what that person has noticed can be helpful as well. So there's no one question or answer that's going to nail it. You're really looking for indicators of significance. And in particular, you want to think about if there is current or past substance use, the relationship of the symptom to the use should also be asked. Did this happen when you were not high or drunk? And these materials are available on the headsuppaorg website. There are some other screening tools that are available, just to be sure you're aware of those, that can be used in various contexts. So we also do have a flow chart for early psychosis screening for young people age 10 and under. The previous was for age 11 and up. As you may have noticed, we age norm from age 11 and up, the prime screen. We have not done that in younger ages. And so here we have some additional questions and considerations for young people who are age 10 and under that you can follow through, with a conclusion being to, in some cases, to consult with the Telephonic Psychiatric Consultation Service Program, or TIPS, which is available throughout the state of Pennsylvania. Now, I've been talking about positive symptoms, the hallucinations, delusions, or subthreshold delusions and hallucinations, and those are often the focus when we're thinking or worried about someone maybe starting to develop a psychotic disorder. But it's important to also consider early negative symptoms. So that's where a person maybe experience a decreased interest or pleasure in things they used to enjoy, lower motivation across activities, so both school and work, and not just changing their interests, like sort of being less motivated to do things across a range of activities, withdrawing socially, or appearing to have diminished facial expression, emotional expression, sort of seeming blunted or even flat. Those are symptoms that can, in some individuals, precede the onset of positive psychosis symptoms. So they're important to think about. They can be confused because very naturally with depression. So it's important to ask a person, about their mood, how are you feeling, as well as about whether they're interested and motivated to do things. Also noticing what we think of as subthreshold thought disorganization, where a person may be having difficulty organizing their thoughts, appearing confused, or having trouble focusing or paying attention over long periods of time, and their speech may end up sounding sort of jumbled up in the way that it's coming out. An overall low or decline in functioning that seems not really explainable by anything else. And as I mentioned, a family history of psychosis. And once again, those comorbidities or the context is important. Depression, anxiety, substance use, trauma. But those things are not mutually exclusive with a prodromal stage. So some young people do experience psychosis spectrum symptoms in the context of other comorbidities. Attention deficit hyperactivity disorder as well is important to consider. So one point here is that if you're looking at a person in a given point in time, things may lack some clarity, and that's often the case in the early stages of psychosis. So it's important to monitor the evolution so that you can check out what's happening over time. For some young people, these symptoms may go away and they don't have them anymore. For some young people, they may stay the same and kind of stay at this, at a level that's not really bothersome or interfering for long periods of time. It's sort of who they are. But for other young people, we know that they can develop into a significant psychotic disorder, and that is where we want to make sure we're getting people to the specialized care that we have available. I thank you very much for your attention.